Good afternoon, and thank you for joining our Systems for Action Research and Progress webinar today. Our theme today is strategies to achieve alignment, collaboration, synergy across delivering financing systems. Our subject today is optimizing governmental health and social spending interactions. And this is today's agenda. We have two presenters today. The first is Beth Resnick. Beth is the Associate Scientist and Director of the Office of Public Health Practice and Training at the Johns Hopkins Bloomberg School of Public Health. Our other presenter is David Bishai. Dave is a professor at the Johns Hopkins Bloomberg School of Public Health, and he directs the school's interdepartmental program in health economics. And we also have a commentary speaker today. Our commentary speaker is Mac McCullough, who conducts research involving quantifying investments in public health and social services and on assessing how these investments are put to use in order to improve population health. Dr. Resnick and Bishai, would you like to start?
Sure, great. Thank you so much.
Thank you.
Yeah, so thank you again for the opportunity to share our research today. We're going to be talking about how we are working to analyze state and local governmental health, public health, social, and community service spending. Ultimately, what we're looking at is how we can maybe align such spending to reduce health disparities. So this is our research team, and one thing that we have the luxury of is that we are building on some prior research that we've already done that was funded by the De Beaumont Foundation. And so what we're going to be doing today is talking to you about the work that we've already done to build the state health expenditure data set. I'm going to be giving you background on what we did and how that data is available if anyone would like to access it. And then I'm going to turn to Dr. David Bishai, who's going to talk to you a little more about what our findings have meant from our prior work, as well as what we will be doing in the future under this RWJ grant. And then we'll have discussion, and we have the pleasure of having Dr. Mac McCullough with us, who's one of our partners who is also with the Maricopa County Health Department. So again, thinking about the practice implications of this work. So with that, I'm going to jump right in. This is kind of a busy slide, but there's key things here that we really want to talk about that underlay all of the different work that we're going to be doing, both our prior work as well as our future work. This seems like a really simple question at the top. How much do we really spend on public health? And there's a couple different things going on in this question. The one, obviously, how much money are we actually spending is a key question that we'll be talking about. But also, how are we defining what public health is? So I'll be getting into that in more detail in some of our other slides. So if you look on the left of this side, the blue graph there, you can see there's a tiny little yellow sliver at the top. So in our national estimates of total non-hospital health spending, it's called the Public Health Activity Estimate. Again, that's all federal, state, local spending. It's estimated that about 3%, that little yellow sliver, is what we're spending on public health. But in reality, when you move over to the right, what does that actually mean? So we know that public health spending includes governmental, the federal level, the state level, and the local level, which can get confusing. And you can see there's estimates here on the right that are highly varying. If any of you are familiar with those estimates, there's ASTO, there's the NACCHO estimates, there's the TIFA, and they're all measuring different things. Some of them are local spending, some are federal, some are state. But this national number on the left, where we're actually getting our estimates, comes from the Census of state and local government data that we'll be talking about. So what we're trying to show you here is the census data is the one that's actually used to come up with these national estimates. And what we were looking at was, is that census data, what is it reflecting, and then what does that tell us about our national estimates? So first off, a little bit about this Census of state and local government data. Most important thing on this slide is that website at the top, because that is where this data set is available. If anybody would like to look at it, it's on the ICPSR website. And I assume these slides will be sent out, so you'll have this website link. But a little bit about what the Census of state and local government data is. I'll start with the strengths. And basically, well, I already told you it's the basis of the national public health activity estimate, which again is used for all the federal budgets and looking at nationally what they think we're spending on public health. Another key point of this data is that in many of these other estimates, you're only looking at health department budget data, whereas the census of government includes all government agencies. So for example, the state environmental agency that might be doing public health work there, the Department of Agriculture, so it's across all different state agencies, which is something different than what many of our other estimates have. And it also has very highly detailed line item expenditures. So example, if you're thinking about like your credit card bill and you have each line item of what you spent, same thing, we get each governmental agency, every estimate. So we're able to really parse down, which again, I'll show you in some future slides. So of course, every data set has limitations. So the limitations are that different states might categorize their spending differently. So for example, if you have a coalition that's working to prevent obesity, somebody might budget that under chronic disease, somebody else might budget it under coalition work. So different states might categorize things differently. And then additionally, the census then gets that data and then they code it to their categories. So it's basically getting coded twice, once by the state, whatever they've categorized it as, and then the census. But just to be clear, all the data we have is the census has coded it all as non-hospital health spending, code 32 it's called. The other big limitations are that California does not submit their data to the census, so we don't have California. And also there were some weird inconsistencies, like South Carolina seemed to be coding, their coding seemed to be different initially for the first years we had it. So this data set has data from 2002 to 2013, and like I said, it's available at that website. So just showing you a little bit about how we categorize. So this part is part of the answer to the question is, what is public health? How are we defining it? So we use this coding framework built off of the foundational public health services model. So everything on the left that's under the green background is what we categorize as public health, population health level services, and then on the yellow on the right falls into other health services. So you can see the different buckets that we've categorized. The nice thing about this is that we have numbers for each of these categories, so you can actually see state level spending across all of these different categories. So again, just to keep in mind, we'll talk a little bit more about local, but this expenditure set is state health agencies only, and we'll talk about locals in a little bit. So this is the coding framework that we used. And then drilling down into this, so if you look at on the left side, we had public health services. So this is breaking down of the total number that the census has for public health. This is the percents that are going to these different categories. So you can see maternal and child health there is the biggest chunk of money, 33%. A lot of that is actually for WIC, Women, Infant, and Children program. But you can see that we were able to break it down in a much more detailed way than you're normally able to see. Next one, going a little bit further, this is the other health services. So again, you can see that these are bigger percentages of the total pie of public health spending. 35% of this is behavioral health services. 27% is clinical services. So you can see that a big chunk of from the national estimates that we're counting as public health is actually really more on these other health services, which is important to know when we're trying to think about what is the impact of spending on different public health activities. So this slide is basically summarizing what I just showed you in the last two slides, that basically money that we are counting in the bucket of as public health, really only 39% of that, according to our coding framework, is public health spending. And then you can see the biggest other chunk, the 22% orange, is behavioral health. So again, this is really important for us to think about in terms of thinking about the impact of different spending on different services, as well as just having a better understanding of what money we're actually getting and how it's being used. So back to that, the original graph I showed you, what are we really spending on public health? So again, this is the national estimates of all spending, and just so you know, we added back in federal and local dollars so that this red line on the top is the national estimate of all public health activity. Using our coding framework and looking at, again, how we're spending our money and taking out the behavioral health and clinical services, you can see that what we found is the yellow band there, that it would be somewhere in the yellow band range. So you can see that's about half of what the national estimate is indicating that we're spending on public health. So again, we feel like this has very important implications for understanding better the budgets that we have and how that money is being spent. So this slide is just, again, looking by state. The point of this slide is not for everyone to look at their state, of course you are, but to say what are we spending on public health, because again, this is just to clarify, this is state-level spending, and this is showing, again, using our framework. The green part would be public health, then you can see the legend, but the point we're trying to make here is there's huge variation across all of these states. In terms of how they're spending their state-level money, and that we think that's, again, important to think about when we're, again, thinking nationally, how are we spending our money, and what's the impact of such spending. So to have a better understanding of where the money is going is important. So just to talk a little bit about local level, and then David's going to talk to you more about this. This map, again, is giving you, this is Census of Government local level spending data. This data was not in any of the other data I presented before. This data we're not able to break down in the same way in terms of line item. We just have totals of different categories, but we don't have line item breakouts like we did for the state data. And this number is giving you per capita how much local governments are spending on public health overall. So again, the point of this map is not to look at your individual county, but again to sort of give you a sense of the variety of different types of services and different budgets that are across the country. So next I'm going to turn to David Bishai so he can tell you a little more about our findings on this work and then share about our future research.
Hi, this is David Bishai. I want to check with the chair that you can hear me. Am I coming through?
Yes, this is Kara. Everything sounds great.
Perfect. Okay. So what you're seeing is our key findings, and I hope if you've been paying attention to Beth, you've noticed that there's a lot of noise in this data on public health spending. Some of the noise comes because different states vary in whether they are reporting clinical services, and even when they do report public health, they vary in what they spend their public health money on. This might have flashed right in front of you, but 33% of what is public health spending goes to maternal and child health services, and a lot of that is for vaccines. So it's very noisy data. So I'm a health economist, and there's a joke about our profession that says there's no data that's so noisy that an economist won't study it. And so we had the courage to go ahead and ask a question whether or not this type of public health spending reported through the census was going to have any correlation with mortality. And surprisingly, in a variety of different statistical models, we were able to find that, yes, there is an association between county-level spending on health and public health and all-cause mortality. Now, the counties, one of the things we'd have to control for is, are the counties rich counties or poor counties, and are they spending on other things? We find that when they spend on public health, they spend on hospital care as well, and the more they spend on public health, it's because they have a lot of money that year. So we controlled for their total revenue that year and what they were spending on hospitals, and sure enough, we still found an effect on mortality. We had a lot of data. There's 2,850 counties. We had to control for something called fixed effects because there might be something special about the county that has perhaps a demographic makeup, different balances of age patterns, race, ethnicity, etc. And we also had to account for the lag structure in the data. We are very concerned with reverse causality. We are worried that counties might try to spend more if they think they're really sick. or the other way. We don't know why there'd be a county that would spend less when it's getting really sick, but we're worried about that. And maybe if in questions and answers you can ask us about the things we try to control for reverse causation. One interesting finding that we've not fully explored is does this health spending tend to narrow or widen health disparities? And so what we find, now these are counties, we don't really know what individuals are, we just know the racial and ethnic makeup of counties. And so we find that when we look at just the counties with the highest proportion of African American residents, the effect size of public health spending on mortality was higher, and higher than it was in the counties which were largely white. So we think that this type of spending by counties acts to lower racial disparities in mortality. Next slide. So what are we going to be doing next? We are working with this data set to supplement it with other types of county spending on social and community spending. We are going to continue analyzing these interesting facts that states can move money from its state budget into county budgets, and they can do a little bit of inter-county transfers. They can help supplement their poorest counties or not. Some states just leave their poorest counties on their own in many ways. And we can look to see whether the states that do try to help their weakest counties tend to narrow health disparities. We want to continue working on examining the impact of this spending on various health measures, looking at various causes of death. We're very interested to see how this spending is affecting the opiate mortality. So we'd like to tell our listeners about this upcoming enhanced data set called SHED-X, which will include these other types of social services in the education, health, hospital, housing, and urban development sectors. All of these data will be coming from the counties as reported to the census, and we'd like to connect them to the state and state spending totals and looking at the transfers. Those transfers can be substantial. When we looked for the 13-year span from 2000 to 2013, these transfers help counties spend for many things. Behavioral health was one of the largest, including clinical care and public health. So the state is trying to rebalance among its counties. And this is obviously a big political football. Sometimes the rich counties have a political sense that they want this to happen. Sometimes the rich counties don't want it to happen, and different states solve that political question differently. But until we look at it, there really isn't an evidence base to see what happens. So what have we found so far? We find, as Beth was saying, that if you just look at the official government estimates of public health spending in America, what is actually included there is very little is actually public health. Less than half of what the government reports as public health spending really meets the foundational capabilities framework definition of public health. So understanding that is going to be helpful. We can now look at the SHED data, and because it's broken down at the state level by spending category, we could actually ask more fine-pointed questions about the different things that states spend on and how that affects health disparities and health outcomes. So that's what we're finding, and we'd like to turn it over to our discussant now.
Fantastic. Thank you very much, David, and thank you, Beth. It was I'm biased. I may be a little bit weird, but I find these to be a really important and actually fairly exciting source of data for the field. So a couple of my takeaways as I'm involved in the project and hearing the work that you and your team have done previously is one of the sort of the biggest top-level takeaways is I'm sure almost all of us on this call are familiar with the old adage that we get very little funding in public health and extremely little relative to what we spend on health care. We've probably all heard, estimates of 1 or 2 or 3%. And unfortunately, I don't have great news today. It looks like we actually get less than what we thought we got. So it's sort of a litmus test here. The glass half empty view of that is we get even less than we thought. The glass half full view of that is that a lot of times how we measure the impact of public health spending is by taking these spending estimates and saying how much does mortality change, how much do birth outcomes change, what sort of outcomes do we get from the dollars we invest. And I think prior to sort of this generation of research, we may have been using the wrong numbers to figure out what we're actually investing. So a couple of sort of digging a little bit deeper on that is of the, let's say, let me actually back up just a little bit. Starting sort of from the biggest upper level here, we know from these data that a lot of public health spending comes from state and local sources, not just federal sources. So a lot of us have probably gotten rightly worried when we talk about the Public Health Prevention Fund going away at the federal level. But for better or worse, we also have other fronts in the battle. So really the fight for public health funding is active at all levels, local, state, and federal. Because if the only thing that we ever talk about with public health financing is federal, we do risk losing sight of a major source of funding for public health. And I don't want us to lose sight of state and local sources. This work actually enables us, I think, to account for what we're spending. For example, the states are spending, locals are spending, and what we're seeing here is that we're actually spending a lot on what we wouldn't consider essential public health services. So one important thing to note is, at least my takeaway of this is that it's not a bad thing that states are spending a lot of money on behavioral health, clinical care, environmental remediation, and the like, but I'm not suggesting we should let those other sectors sort of wither away so that we can fund other essential public health services. Rather, again, it's that we need to be more precise with our discussion of what do we mean when we talk about public health spending, because it's conceivable that we do care about those other sources of spending, and we should include those in our estimates of what we spend, and it's possible that we specifically should not include that. Just sort of talking about the data a little bit, in my experiences, there seems to be a little bit of a disconnect between the budget folks, the program folks, the policy folks, and I'm excited that hopefully more folks can become aware that these data are collected. And through the work of Beth and David and the team, there's another really important collaborator that's not presenting today, but JP Leiter does a lot of work on this as well. These data are being made available for analysis. So I think that this point is especially important to drive home because in some of my experiences working within the county government, within the public health department, across other counties and state governments, when I go and talk about these data and the importance of measuring spending, a lot of times the reaction I get is either we had no idea those data were available, or you should go talk to this person. I think they could probably get you those data. And it's always fun to be able to say, actually, we have a lot of the data. It's noisy and it's messy, but we have it. And so I think we have a fantastic resource here that I'm really hoping more of us can become aware of its availability. So another thing to sort of take away from this is thinking back to that map with the state level pie charts that Beth showed earlier. It brought up sort of an uncomfortable truth for me, and I think others have probably noticed this too, but what we hear in the literature often is that every dollar invested in public health is incredibly effective, has a huge return on investment, huge impact, and it's sort of the uncomfortable truth of it is that is it really possible that given the variety of categories that we're seeing, that every single dollar is equally effective and equally impactful? So it doesn't mean that we view ourselves as some sort of know-it-all expert who are going to come to your state and reallocate your public health dollars. But I do think there is an opportunity here in that budgeting and finance aren't necessarily widely held competencies across the public health workforce, and that's something that other public health workforce groups are working on. But conceptually, a lot of us have gotten involved in public health to improve the health of populations, not necessarily to track budgets and spending. But our point is that there's opportunity here to do more of the former, so helping health of the populations, by getting better at the latter, so getting better at spending, tracking what we're spending and budgeting. I think there's some great opportunity there. We also, just sort of as we're thinking about budgeting and managerial competencies, it's also important to point out that thinking back to the slide that had the red line that shows what our official estimates are versus the yellow band that shows what we, with using the shed, may want to revise our thinking to believe our actual spending estimates are. Public health leaders spend a lot of time, thank you very much. Public health leaders spend a lot of time during the week managing that red line of spending. So that's public health, behavioral health, primary, secondary, tertiary clinical care, environmental remediation, other services. But we actually think about the yellow band while trying to manage the budget for the red band. So there's a little bit of a disconnect there. So I think this work, along with some other work from, for example, Betty Beckemeyer with the Public Health Activities and Services Tracking Group, we're all trying to sort of hone in on what do we actually spend on essential public health services and what do we spend doing other non-public health things. And it's not that one is better than the other, but through this work we can more reliably and with a little bit more validity get at the impact of public health spending on population health. So I think I will leave it there. And once again, thank David and Beth for allowing me to provide a little bit of commentary on this.
Thank you, Mac. This is C.B. Mamrell. I just want to check if my audio is coming out clear. I'm filling in for Rick, who had to step out. And thank you again. And before we get to the questions of the audience, we just want to give David and Beth a chance to respond and comment on Mac's comments. So I'd just like to turn it over first back to you, David and Beth.
Sure. I wanted to thank Mac for those insightful comments, and I would just echo that, we really have to be honest about the variability in how different states are spending their money, and as scientists, try to help make that spending more efficient. On our advocacy role, it might not be helpful to say that every dollar is wonderful, and we're going to actually end up finding that no, there are some ways to spend public health dollars that are not that effective, and there might be some states that haven't been doing a great job. So it's going to be a sort of an uncomfortable moment in balancing, finding out the scientific findings and balancing that against what we would like to be true, that every time a public health department spends money, it's wonderful. But that's how we create accountability, and part of the beauty of America is having these publicly available data sets for the academic part of our country to help the public sector do better.
And this is Beth. I just want to echo that, and thank you, Mac, for your insightful comments. But I think even what David's saying, absolutely, but even more fundamentally, especially for the practice committee, the practice community, we're often so busy putting out fires doing our job that nobody really thinks about the big picture. Just like we're at the beginning of the year in terms of our personal finances, trying to get a better sense on what we're spending and where it's going. So in addition to the tough questions that David and Mac both referenced, just even having a better understanding of how we are actually spending our money and where it's going, I think is a huge step forward for the field, understanding that all these different buckets and where we even are, and then getting to those harder questions. But even that first question of just understanding all these different buckets and how the money is being used, I think is a critical first step.
All right, thank you very much. And we'd like to turn over to questions from the audience. And so please don't forget, you can type in your questions in your chat box, and you can also direct it either to Beth or David, or even to Mac, or even JP, who I think was on the line right now. So let's get to the questions. And we have our first question from Joanne. How do you categorize supportive services to frail or disabled persons, like wheelchair transport or home delivered meals?
So I can answer that. So as I was saying, the coding is kind of complicated. So I'm showing you this coding framework that we use. So each state might have categorized things differently. So for that example about frail or elderly, I think it was, right, or wheelchair, if the state coded that as disability, so we have all those line item records, then we would have put it in disability. If they'd categorized it as something else, again, so depending on what the state categorized it as. But we had a coding scheme that we used, our teams, and we had two teams working on these things, and then we would compare findings. But basically, we would, again, looking at this coding model, yes, it's definitely public health, and we could drop it into one of those boxes on the foundational public health services, or no, it wasn't, and it would fall under other health services. So, for example, if it was coded as disability. If there was something we weren't sure what it was, like some weird item, then we maybe put not uncertain. And then once we finished all the uncertains, we ended up, to be conservative, we actually included all of those as public health. So our default was that it was, if we couldn't determine what it was, then we put it under public health other. So actually, in real truth, that number that we said was probably a big overestimate of what we're spending on public health. It's probably even a little bit higher, because anything that we weren't sure about, we actually were conservative and counted that as public health. So bottom line, the answer is, depending on how the state, what the code line for in the state budget was, that's whether we would have counted that as disability or some other funding.
We have a question from Kim. Can you say more about how you went about coding the SHED data based on the foundational capabilities? We tried that for our state agency chart of accounts and found it exceedingly difficult. So I guess it just builds on what you were discussing, but can you just say a little bit more on that, Beth?
Sure. And again, yes, sometimes it was complicated, but again, the beauty of this data set, it was so big and across all the states. So again, even if our exact buckets aren't exactly right, I think we're pretty confident that over the time period 2000 to 2013 from all, well, not California, but all the other states, that we think the percentages were fairly confident in that, the splitting out. But again, you're right, each state, you have to make some judgments based on what they were coding. And again, this data was everything that we were looking at. The census had taken all that state data and put anything that the census had categorized in their code 32, which is non-hospital health spending, was what we were looking at. So again, the line item that the state put it under, and then the census had to then take that and say, oh, that's code 32. So that's what came to us, and that's what we were looking at. So I guess the caveat is, in your individual state, as Mac was talking about the pie charts, they're all a little different. So if you were disagreeing a little bit with your own state, that could be true. But when you're looking overall at the way it fell out across the country, we're pretty confident in those bigger numbers.
This is David. Let me just add on to the answer to Kim's question. It takes a lot of time and effort, and we were fortunate to have funding from de Beaumont to do it. And we knew that because it was so time intensive, it was unlikely to get done a lot. So while we were doing it, we taught a machine how to code the state data, and we published a paper last year on our results from machine learning. And we were pretty pleased after we taught a machine to do the same type of coding by looking up the string data that we were looking at with our human eyes. The machine could do it the same way with about a 79 to 80% agreement rate. And we're willing to share that R code with anyone else who doesn't have the time and budget. And for the census, if they want to do this coding in the future, rather than having a large grant to have human coders, a machine might be able to fill in the gaps.
And this is Mac, just one more thing, and I'm not in the same room as David and Beth, so they were not going to be able to pelt me with rotten fruit for saying this, but one sort of thing that I see as I look at this is we're sort of implicitly taking the approach that we definitely want to parcel out everything that isn't these essential public health services so we can know exactly what we do spend on what our common understanding of public health is. But down the road, I think it could be a fantastic opportunity if, in many circumstances, we want to know what we spend on behavioral health plus public health. If we take a multi-sector approach at all this, it doesn't maybe make sense to start parceling things out. We may want to start carving things back in, and maybe your department cares about categories 1, 3, and 7, and we can compare only categories 1, 3, and 7, rather than having to sort of talk about different. We think we're talking about the same thing, but we're actually talking about two separate things, and we've just lumped it all together. So I think there's a lot of opportunity to this as we move beyond just talking about public health as a sector. I think really this is an effort to get at how do we actually know what we know about what we spend on things to make ourselves healthier.
Actually, Mac, we won't pelt you with fruit because I agree with you 100%, and that's exactly why we did it in this bucket way, so looking at this coding framework. So if people are really interested in looking at the impact of their clinical care services, they have numbers in each of those baskets as well. So it's not, and again, our key thing that we originally started with, it was looking at it from the public health, population health services impact. So that's why we were using that foundational public health services model. But again, this data is available intentionally for people to use it in whatever way is most helpful to them, whatever side or whatever components of this coding framework that there is. So I agree with you 100%.
Excellent. We have actually two questions from Joanne, who asks, are you linking ShedX to any health information exchanges or doing analysis together? And then she also has another follow-up question, whether medical care is organized with extensive overlapping market areas, while public health is organized from the start as geographic responsible for all in that area. So alliances with data from medical care is challenging. Have you seen some breakthroughs on this? So
this is David. The answer to the linkage with health information exchanges is no. It's an intriguing possibility, and maybe we should talk offline about how to do that. One of the questions that we've talked about is, can better public health spending save the medical sector money by, this dream scenario of preventing disease and lowering spending? And would love to be able to do that, but we just, we focused on getting our coding right and adding in other sort of distal determinants and social determinant type of things that counties do, and not getting into the more proximal things that doctors and hospitals and pharmacies do. So that's really where our focus has been, but it's a great opportunity to think further.
Tamara asks, is there information on the specific sectors that are included, for example, housing, education, transportation, and how those numbers are collected, what they include? Would this be on the website?
Yes, Tamara. That is going to be what ShedX is about. The X is going to be to extend the current data on public health spending with these other things that counties have been reporting. And just to take a look at what is there, The counties report their revenue from alcohol, beverage taxes, tobacco taxes. They report revenue from their individual income tax, and then they report what they spend. And they spend on elementary education, higher education, fire, their court system, their highways, their libraries, natural resources, and welfare. So it's very rich, and it's going to be what we do in this project to augment our current public health data with this social spending data and look for patterns.
Suzanne asks, I have been trying to research how the recent tax reduction legislation for reducing 16 cents of the alcohol federal tax will do for federal funding to both the Department of Tobacco and Firearms budget as well as funds sent to CMS for behavioral health prevention. Do you have any details on this and for public health dollars?
For Suzanne, the data we're looking at is not federal, so we will be able to see what counties report down at their level and getting that micro variation in alcohol tax, which I think as a researcher is going to tell you more than trying to parse out the effects of a tax that's the same across the whole country. So stay tuned for SHEDX giving us this micro-geographical variation in the alcohol tax revenue as well as even tobacco tax revenue.
Teresa asks, is there a place in your framework for money spent by hospitals towards community health and or community building, that is the community benefit spending, either at the local or state level?
So for Teresa, yeah, go ahead.
Go ahead. I was just going to say this is the Census of state and local government spending, so it wouldn't capture hospital spending unless the hospital gave the local or state government a grant. But it's just governmental spending.
But Teresa, I think I'm reading your mind. I would love to have a database on the community benefit reports of the hospitals across space to try to see, if that is effective. I think I'm not optimistic that the hospital community benefit spending is going to be very productive. I've looked at some of the hospital community benefit reports and have been a little disappointed on the things that they choose to fund. But I think we don't know the answer until we've done something like merge in a large database on community benefit reports. And the IRS has them. I don't know if anybody in this call might know of research in progress that is trying to build a database of community benefit spending.
Maria asks, did you find any data associated with providing health care or social services in county jails?
So I don't see that as a line item at the county level. I would have to go back to our state records to see if it gets broken out as a line item. One of my other colleagues and I have been looking at correctional spending, and again, it's one of these very difficult things where you have to look at spreadsheets that are reported. They're in the public domain, but nobody ever broke out the health spending inside correctional institutes. But it's a good question.
And I think we have one last question in the queue, and this is from Phyllis. Can you say more about how the state reports public health spending to the census? Are they using a common set of categories, or do they report based on state budget allocations or some other way?
So again, this is like into the weeds of the complication of how accounting coding happens. So there is no set categories. I think that's why the project that Betty Beckmeyer is working on, like a chart of accounts type thing. So each state will do it slightly differently according to their own categories. Additionally, sometimes when in our work, which is why we're excited in this new project that we are going to reach out more directly to budget people both at the state and county level to find out how they're categorizing things, and then who's actually reporting to the census. It's usually somebody in the state office of budget and management, which is a different person than the state health department person who's doing the categorizing. So again, there's a lot of different layers and levels of this. So the bottom line answer is that every state is doing it a little differently. And again, we're excited about this future work to get a better sense about that and a little bit more nuanced in terms of state and local level, talking with more budget accounting folks and sharing this information with them as well.
Okay, actually there's one more from Suzanne who wants to ask, is there any way to gather more current year data in ShedX or somewhere else? 2013 seems so long ago for relevance today.
I know. Doesn't it feel like 2013 was just yesterday, though? It does to me, but maybe I'm getting older. But actually, good question. We've actually been in touch with the census. They've had a lot of staff changes, but we actually think now there's a new person in there that we're planning to add the data for 2014 and 2015 as soon as we can get it. And the nice thing is, as David said, we've trained the machines, and we already have done the coding framework, so we should be able to add the new data. Now the social service data we'll have to add in, but the the ones that we've already coded, we can use our framework and use the machine to get that data added in pretty quickly.
Thank you. I think there's a lot of interest that's being generated from your study, and we just want to let the audience know that if you have any more questions, you can either direct it to us and we can forward it to Beth and David, or you can also direct it directly to Beth and David. So we do want to thank our speakers and commentators, especially Mac and JP too as well, for their time and input. We especially want to thank Beth and David for their first Research in Progress webinar seminar on their important study evaluating the alignment of state and local government financing systems for health, public health, and social and community services in order to reduce, or that can help reduce health disparities. We want people to know that their research team is part of our new cohort of grantees that are being funded as part of the Robert Wood Johnson Foundation System for Action research program. And so we look forward to learning more about their study as it moves forward. So thank you again, Beth and David, for your time and presentation. And we do want to let people know that this presentation will be available from the Systems for Action website. So for those who want to get a copy or download it. And we do also invite you to take a look and join us for our upcoming Research in Progress webinars, the schedule which you can also get from our website, from Systems for Action website as well. So once again, we do want to acknowledge and thank the support of the Robert Wood Johnson Foundation for this program. And we do hope to see you again soon. And so we wish everyone a good day, and thank you for joining us.